I have been a physical therapist now for 35 years. I graduated when I was 12. And been, as I said, specializing in this area for about 15 to 18 years. So if you've got a question that I can't answer, I'm going to give you a gold star. So I appreciate you taking your lunchtime and coming and listening to this. If I'm in the way and you can't see anything, just ask me to move, okay? So a lot of people think what I'm going to be talking about is I'm going to be talking about the bladder and the bowel. I'm going to be talking about incontinence. I'm going to be talking about overactive bladder syndrome. And I'm going to be talking about different things about the bowel as well. And I talk fairly fast, and sometimes I say things a little bit different. So if you don't understand me, put your hand up and Rod can translate for me. Not that he knows me very well, but anyway. So people tend to think of the pelvic health world as just strengthening the pelvic floor. And by the end of this, you should be realizing that there's a lot more to pelvic health therapy than this. Just so you know that the section on women's health was actually formed in 1977 within the American Physical Therapy Association. So this is not just Vicki Lukert standing up here talking about something that nobody else knows about. There are therapists all around the country, all around the world who do exactly the same thing as we do. And we actually have, at our facility, we actually have 5 therapists who specialize in pelvic health. So we have quite a large group, and I would say one of the larger groups in the country actually working together. So when I'm going to start off by talking about urinary incontinence. And when I talk about urinary incontinence, that's when you leak urine when you're not supposed to. Okay, when you're on the toilet and you're going to the toilet, that's great. But when you're leaking urine, when you're not on the toilet, that is what's termed urinary incontinence. And it's actually more prevalent than any other chronic disease in women. And I'm going to be talking about the fact that it is more prevalent in women than men, but there are men out there who do have urinary incontinence, and there's a lot of men out there with the overactive bladder. So the incidence, 15 to 25 million Americans, 15% of adults have some form of urinary incontinence. That's pretty high. This is something that we don't tend to talk about, so people don't tend to seek help for it. You know, we don't go to a party and we say, you know, I wet my pants last night. You know, we just don't do it. We don't tend to talk to our friends. We try and hide it from our spouses. So sometimes it takes a long time to seek help. Greater than 50% of nursing home residents have some type of incontinence, and we have certain programs that we apply in the nursing home. It's a little bit different than what I'm going to be talking about today. Women twice as likely as men. We have babies that go through, I'm going to be talking about our pelvic floor. We have babies that go through the pelvic floor. We have a shorter, am I in the way of your camera? No. We have a shorter urethra. There's all sorts of reasons why women are twice as likely as men. 26% of women between 30 and 59 years old have problems, and most people think urinary incontinence is actually for the elderly only, and it's not true. 47% of regularly exercising females have incontinence, and 22% of these have not had children. We tend to think that incontinence comes with women who have had children. So if you haven't had children, it doesn't mean that you won't have incontinence. An interesting piece of information is 60% of patients with low back pain have incontinence, and I'll talk to you a little bit about why that happens as we go on through this program. And then post-prostatectomy. So for you gentlemen, hopefully you won't be going through having a prostate removal, but one of the side effects of having a prostate removed is actually having incontinence, and we have a very strong program here at UF Health that takes care of that. But if you're good and you do what I tell you now, you mightn't have incontinence afterwards. So there's different types of incontinence. I'm only going to be really talking about these 3 here, and then the overactive bladder up over here. So stress incontinence. So this is the incontinence that when you jump or you laugh, or you get on a trampoline, you cough, sneeze, and you leak. And this is because there is, here's your little bladder here, and what happens is you have too much pressure that counteracts, here's your pelvic floor here. The pelvic floor is not strong enough to counteract the pressure that's existing on the bladder. So it squeezes the bladder, there's not enough strength here, and your urine comes out here, and that's called stress incontinence. Urge incontinence, however, is associated with a strong sense of urgency. So it tends to happen to people sometimes, like when they're walking to the toilet, or when they're running water, when they're arriving home. What happens with this particular type of incontinence is, here's our bladder wall here, and the bladder itself is actually a muscle. It's actually an autonomic muscle, and this muscle actually contracts and causes a leaking down through the urethra here. So this comes from like intrinsically within the muscle. So there's two different types of incontinence. The urge incontinence, on the way to the toilet, you'll often have urgency and frequency with the urge incontinence. Some of the other triggers is when you arrive home, cold weather, walking by the frozen section at the grocery store. You know, you can suddenly go, oh, I got to go to the toilet when you're going grocery shopping. That's our little bladder saying, hi, I'm here. And I'll talk about how we actually do control that. And these are the tips of what I'm going to be giving you tips and ideas, so it's not just information about incontinence that I'm giving you. I will be giving you some tips. The mixed incontinence, and this is usually what we see, is a combination of both. So just to reiterate here, the two types of incontinence that we're talking about is the stress incontinence, where the stress comes from the outside, and then the urge incontinence, which is occurring from the bladder muscle itself contracting. So just a little word for you guys about why we have incontinence with following a prostatectomy. When they take the prostate out here, they're actually taking part of the urethra out, and they're also taking the external sphincter here. And so what happens is you've got a decreased amount of resistance of the urine coming out, but one of the little muscles that was used there that was taking care of the incontinence is not there anymore. So what we have to do is train you how to do the pelvic floor contractions again, to wake this muscle up again, and to stop you from leaking. So that's the reason why we have the incontinence following prostatectomy. So the overactive bladder. The overactive bladder is that you've seen the advertisements about the guy, the going man. You know, he's always going to the toilet, and the urgency and frequency. The overactive bladder doesn't have to have incontinence, but it can be very limiting in itself, because if you're going to the bathroom we see some people who are going to the bathroom every 20 to 30 minutes. I want to be talking about what a normal void schedule is like. That should be. So every 15 to 20 minutes is too much. Even every 1 to 2 hours is too much. Getting up for, there might be a few people over 65 in here, but for anybody, you can pay me later. For anybody under 65, you shouldn't be getting up at night at all to go urinate, unless you've had a really good night with the beer and the wine and the champagne. But you really shouldn't be getting up at night to go to the bathroom. So if you're getting up more than 1 to 2 times a night, and you're going more frequently during the day, then you might have an overactive bladder. You might have heard of the interstitial cystitis. I'm not going to be talking about that, but that's a very severe form of the overactive bladder. So overactive bladder is more common than asthma and heart disease. And once again, you know, people don't tend to talk about it, but you might notice your friends going more often than you do, and you can tell them, look, I went to this great lecture, and you need to go see these people, because, you know, what she had to say really made sense. I couldn't understand a word she said, but it made sense. So some of the things that happens when we have overactive bladder or incontinence is we start avoiding trips and travel, and we actually start limiting our trips to where we know that there are toilets. We start doing what we're calling toilet mapping, and you're going to understand this as I talk a little bit more about the education. Like there's people that we know that know exactly where the clean toilets are between Lake City and here. Now, and when they start approaching that toilet, they think to themselves, oh, I'm lucky I'm here, but you're going to understand it's actually the bladder that's calling out, hey, you know, I'm getting close to this toilet. So things like toilet mapping. You should be able to make it from Lake City to here without going to the toilet. So people start reducing their fluid intake, and if we know anything about health and well-being, that we know we have to keep our fluid intake up. We need to be drinking water. Water is one of the main things to actually create health and well-being for us. We start avoiding exercise and physical activity. And you guys are all here, that this kind gentleman was telling me about the program, and I think it's fantastic that you're all working towards increased health and well-being. And we know, I mean, there are studies out there that say that exercise and physical activity improves our health. I know it's strange, but you guys have read those ones, right? You've heard that. So when people stop exercising, their health starts degenerating. People start doing less productivity at work, and they also start missing work because of overactive bladder and with incontinence. So some people start decreasing their socialization. They stop going to church. Their fear of actually leaking in public or having an odor. So this can be quite debilitating as well. They might start wearing dark clothing. See, look at Rod. He's wearing his dark pants there. Now we know why. Also, people start avoiding sexual intimacy. If they're having leaking, they actually start avoiding. So that's another very important part of our lifestyle that we want to maintain. Also, losing when you add all these things together, we start losing a little self-esteem there. So, a fear of being a burden, another one. So, multiple barriers to treatment. People don't want to admit that's happening. Oftentimes, physicians don't even know that there is physical therapy or something that can be done to help. Some people ask for help and they don't get sent. So there's all sorts of barriers to treatment. So there's always someone somewhere, and like there's so many physical therapists out there who do this work now, that there's somewhere that can be helped. So if you've got loved ones in other areas, there is also physical therapists out there that can help with this. Okay, so physical therapy. So I'm going to talk a little bit about what we do. We do a very detailed, extensive history, and part of this is because when you come back in 4 weeks, you know, we will see you like once a week or something. Then after the 4th week, and you say I'm not doing much better, I can go back and say, well, you know, are you dry at night now? And you go, well, actually, yes, I am. And I go, well, you weren't a month ago. But you say, because men are always like this, men say, well, I'm still leaking in the afternoon. And I go, well, are you drier in the morning? And you go, actually, yes, I am. So if I have a detailed history, then I can figure out, I can show you making improvements. When we do the subjective evaluation, we're wanting to know, different times you're leaking, when you're going to the toilet, how many pads you're using, are you using pads? Like, is the urge associated with going to the toilet, all these different things. I want to know about your sexual function, bowel function, the type of fluids and foods that you eat and drink, and you'll see why this is important. There's all sorts of things we're going to ask. And then when we do the objective evaluation, we do an evaluation where we actually do the same evaluation whether you have incontinence, whether you've got overactive bladder, whether you've got stress incontinence, whether you've got pelvic pain, bowel dysfunction. We do the same thing so that we don't miss anything, because oftentimes somebody with overactive bladder also has problems with their bowel. Somebody who's having incontinence, they might be having, you know, also something else going on. So we do the same evaluation. I want to talk about the pelvic floor muscle. Who's heard of the pelvic floor? Or wait, so let's make it harder. Who hasn't heard of the pelvic floor muscle? You have not heard of the pelvic floor muscle. Have you heard of the Kegel muscle? No, you've never heard of the Kegel. Well, you mostly don't have one because you're a man. No, I'm just joking. A lot of men think they don't have a pelvic floor muscle, and it's not true. So the pelvic floor muscle is the Kegel muscle. The pelvic floor, here, wait a second, I'm going to just put this down for a second. I don't want it to pull in. Okay. So here's our pelvis. I'm going to show you that, and so you can see it up here, but here it is, the pelvic floor muscle. Can you see it here? Okay. Everybody see our pelvic floor muscle? There's a reason it's called floor, okay? It's in the base of our pelvis. It's in the floor of our abdomen. And it has several different functions. It's a sling, or acts like a sling or hammock. This is looking down on the pelvic floor. This is looking at the pelvic floor on the side, as if I've been cut in half and you're looking at me like this. And it has several different muscles in it, but it acts like a sling or hammock in the pelvis. And so one of the functions of the pelvic floor is to actually support our abdominal and our pelvic contents. Now, this is more important oftentimes for women than for men, because we often have babies that sit there. We have babies that go through it. If the sling or hammock is like, imagine that you put a hammock out in the beginning of the summer, and it's nice and taut and nice and strong, and then fat Uncle Albert comes over and lays in it for the summer, and next thing you know, it's saggy baggy. Okay, so we can't restring it. What we do is we strengthen it. So that's one of the functions, is to support our abdominal and pelvic contents. For men, if you're doing a lot of Valsalva, like heavy lifting, holding your breath, you're carrying extra weight, or even runners who have lots of repetitive strain on the pelvic floor, it could be influenced there. This is the muscle that we're going to use to maintain bowel and bladder control. It's the muscle that we're going to use to stop ourselves from leaking, but it's also the muscle that we're going to use that's actually going to help with that sense of urgency and frequency for the overactive bladder. This muscle also is the muscle that oftentimes your rectum goes through here as well. So this is the muscle that is often involved with people who have difficulty defecating. They might have pain with defecation, they might have constipation, so this muscle can be involved with this. For men also, I mean, it's associated with pain, so women might be experiencing pain as far as pain with intercourse, things like that. For men, oftentimes this muscle is involved when they're experiencing prostatitis symptoms. We see a lot of men who go to the doctor with prostatitis. They get on antibiotics, and it doesn't make a difference. They come and see us, and we help with this muscle, and it makes a difference. So just this muscle is very important. This muscle also has a sexual function. So it's really great. For women, I mean, we like this. For a woman, it actually increases our ability to have an orgasm and increases our the strength of our orgasm. Why wouldn't you want to strengthen it? For guys, it actually helps with your sexual control as well. So it has a sexual function. It's also a core stabilizer. If you think of our trunk as a can, okay? If I've got a can and it's not open, I cannot crush that can, correct? But if I pop that top, I can crush that can. So if I've got a weak pelvic floor, it's like popping the top of the can. So strengthening the pelvic floor will actually help with back pain, and this is one of the reasons why 60% of low back patients with low back pain have incontinence, because their pelvic floor is weak, and that's one of the reasons they have back pain, because their core is weak. It also, strengthening the pelvic floor actually helps decrease congestion in the area, so after surgeries, and like women with prolapses, things that have fallen down there, will actually help hold them up there. Okay, so here is the pelvic floor in the male. I told you had one. It looks just the same as a female. So the pelvic floor, as I say, is important for both sexes to be strengthening. There's two different muscle fibers in it. One is a fast twitch fiber, one is a slow twitch fiber. The 70% is a slow twitch fiber, and that's the one that supports our abdominal and pelvic contents. Whereas the fast twitch fiber is the one that stops us leaking when we cough or sneeze or jump on the trampoline, things like that. The strengthening of the pelvic floor, if you're going to strengthen your pelvic floor, I said to this male, he was from Scotland, and I said, imagine you're about to meet the Queen and you don't want to pass gas. And he says, I have little regard for the royalty in England. I said, well, if you did. So it's as if you were going to stop yourself from passing gas, as if you were going to stop your urine flow. So that is the muscle. For some guys, when they were young, they would be able to, use it to strengthen their... let's carry on. It's important to strengthen this pelvic floor in our general strengthening process. You didn't record that, I hope. Okay. It's all recorded. Okay, the pelvic floor strengthening. If you were to come to physical therapy and, let's say you're really, really, really weak. I mean, there's people out there, they can barely contract. We might have to use electrical stim or something to actually increase your strength. But once you get stronger, there's actually weights that we can actually insert into the vagina or into the rectum for man to actually strengthen the pelvic floor as well. And you shake your head and you think, oh my gosh, no. But if somebody's leaking, these things can really make a difference, and it means that you don't have to do as many pelvic floor contractions during the day. It's like if you go to the gym. You don't go there and strengthen your biceps and stand there like this and do 1,000. You put a weight in there. So it's the same thing with the pelvic floor. We also do pelvic floor strengthening and function to stop people from leaking when they sit to stand. If somebody's leaking when they're playing golf, we'll actually practice doing it using the golf swing. So different things like that. We also have a biofeedback machine where you can actually use sensors and you can actually see yourself doing a pelvic floor contraction. Because for some people, I know you've all tried to do a pelvic floor contraction, right? You all have done one since I've started talking. Is there anybody who hasn't done, or is there anyone who hasn't found their pelvic floor? Okay. So sometimes it's hard to tell whether you're holding it or not. That 10 seconds, it's like, well, I think I'm still holding it. But if we use the biofeedback, we can actually see on a graph what's happening with the pelvic floor. So it gives somebody a visual, so it really helps with their strengthening. So here's somebody who's not doing such a great job. They can't contract and they can't relax. This is them later, still not very strong, but at least they're getting some relaxation and some contraction. You can see they're not holding it. I mean, this gives me a lot of information about what's going on. Here's somebody who has an overactive bladder, so their resting tone is really high. What I'm wanting with this person is to get this down here so it's lower. So the biofeedback gives me a lot of information. Sometimes we need to do it for general relaxation if somebody's got overactive bladder and has a tight pelvic floor. So I'm going to go through some of the education so that to give you an idea of, particularly for the overactive bladder. The urinary system. The kidneys produce the urine. And then what happens is it actually comes down the ureters, and it comes down by a peristalsis action. It doesn't just drip, it actually moves, it gets pushed down just kind of like the bowel through our intestines. And then what happens is it collects in our bladder, and then we get the sense that we're full. Now, for some people, as soon as they're full, feel like they need to go to the toilet, they're going to the bathroom. Because some good-meaning person has told them they'll get a bladder infection if you wait too long. And that is not the truth. Because if you go too frequently and your urine stream is very slow or weak, then you don't get much of a flushing out of the urethra there where the urine comes out. So I'm going to talk about what a normal voiding schedule is. So going to there is actually 2 different levels of sensation of needing to go. There's one level that says, okay, you need to go within the next hour. And then the next one says, well, pretty much you've got, 15, 20 minutes to go. So if you go to the first one every time, what you're doing is you're creating a smaller and smaller bladder. And then it takes less and less for that sensation of the bladder to feel like you've got to go. And then you're going more and more frequently. And I'm going to teach you how to make sure that you don't go too frequently. This, I'm not going to go through the different reflexes. All I want you to see is there is a very important connection between our brain and our bladder. There's between all these reflexes here. So, here's our pelvic floor muscle. Our pelvic floor muscle, I've talked about, supports abdominal pelvic contents. It is also a voluntary muscle. I say bend my elbow bends. Now, does she only get half points for only staying up? Okay, let's get back to the pelvic floor. The pelvic floor is a voluntary muscle, right? I say bend my elbow bends. You've all noticed that you can actually contract it. So it's a voluntary muscle. The muscle around the bladder, however, is an autonomic muscle. So it's like the muscle of the heart. Now, if I was to see something or hear something and my heart starts racing, nothing physical has happened to me, correct? It's a message between my brain and my heart. So the same thing can happen between our brain and our bladder. And when that happens, when our brain is the one sending a message to the bladder as opposed to it filling up, we get this sudden sense of urgency. There is a difference between feeling full and urgent. And that feeling of urgency is like the heart palpating, but it's the bladder palpating. And if we respond to that all the time, then we're just going to start going more and more frequently. So if you think of the bladder like the biceps too, I mean it's a voluntary muscle, but if I was always contracted here and then I let it lengthen out to here and then I contract it, and I only work in here, eventually my biceps is going to be sore and I'm going to have a problem. So it's the same thing with the bladder. If I don't fill my bladder all the way out, I mean when we're wanting strength in our biceps, do we go in here? No, we're out here to to lift something. And it's the same with our bladder. The fuller the bladder, the more the contraction, the better the urine flow, the cleaner the urethra is. So it's really important to be able to have a full bladder and have a normal voiding system there. If we go to the toilet every time we feel that sense of urgency, it's like giving a child a piece of candy to stop them from having a tantrum. Okay, it'll stop that tantrum, but it'll bring more and more on. You're rewarding a negative behavior. So we don't want to be going every time we feel the need to go to the toilet. So what we do is what's called urge suppression, and there's three things with the urge suppression. Okay, one is, like, I'm going to talk just for a second, like if somebody has urgency, oftentimes as they're walking to the toilet, their urgency will get more. Like they'll feel like they've got to go more. I mean, is there anybody here that, I mean, I know there's people here that know that feeling, like the closer they go to the toilet, the more they feel the need to go, right? Yes. Okay. That's because of the connection, that brain's going, oh, she's getting closer to the toilet, I'm going to send more signals down. So this is a perfect time to do the urge suppression. The urge suppression is three things. One, what we want to do is, if my heart's racing, I'm going to say, calm down, breathe. It's the same with our bladder. If my bladder's racing, I'm going to want somebody to calm down and breathe. The other thing that I want them to do is I want them to stop thinking about the bladder. I want to stop thinking about the toilet, okay? So I'm going to get them to count backwards from 100 by sevens. Now that's, you know, unless you've got a little brainiac there or a bank account or an accountant or something, you know, you've got to think about that, and you're not thinking about the toilet. And that decreases that sense of urgency. But also, here's where we pull the pelvic floor in. By doing a pelvic floor contraction, it actually has a connection to the bladder. And what happens is, when you do a pelvic floor contraction, it sends a message back to the bladder to relax. And it's called the voluntary urinary inhibition reflex. And it's real. So what happens when you feel a need to go to the toilet and you're heading there and you suddenly it's making worse and you think to yourself, oh my God, I don't think I'm going to be able to make it. Everybody scuttles to the toilet. No, you're going to stop, okay? And it seems counterproductive, but you're going to stop. And you're going to breathe. You're going to think about something else. You're going to do a pelvic floor contraction. And you're going to wait for that wave to go. And you might still feel a little urgent, but then you make your way to the toilet, okay? You're training your bladder that you're in charge, not the brain and the bladder, not the brain. So there's your urge suppression, and I'm going to talk about different situations that you're going to be using this in. Now, to stop the urine test. Some well-meaning doctors say, oh, every time you go to the toilet, stop your urine flow 7 times. You should never do this as an exercise. You can do it to see if you know where that pelvic floor is, but you should never do this as an exercise. I'm going to come back here. If you stop your urine flow every time you go to the toilet, you know, you're on the toilet. That's when you want your bladder to contract. That's when you want it to be doing its thing. So it's on the toilet doing its thing, happy as a clam, and you do a pelvic floor contraction, and it says relax. Then you tell it to go. Then you contract and tell it to relax. And next thing you know, you've got a bladder that's saying, what do you want me to do here anyway? Do you want me to go or start or stop? You know, then you start getting incomplete voiding, and you also start getting difficulty actually initiating the urine flow, because it's an autonomic response of when you sit in the toilet, you urinate, right? I mean, you don't really do anything else. So you don't want to be changing that autonomic response there. Oh, I know. It's my dog. Well, he's dead, but I love to see him. I know. Don't cry, anybody. He was a great dog. But you think of your bladder like a dog. You don't want the dog on the couch, right? So you train it. She's got a dog that goes on the couch. So, but if you don't want the dog on the couch, it's a brand new couch, it's beautiful, you don't want the dog on the couch, you train it. And if you're consistent and persistent with that dog, it eventually stops thinking about getting on the couch. You let the dog on the couch, and it's all over. But it's the same with the bladder. If you're consistent and persistent and start thinking about these things, it actually works. So once again, suppressing the urge is breathing, thinking about something else, and doing your pelvic floor contraction. Okay, bladder health, normal voiding, every 3 to 4 hours. So if you're going 1 to 2 hours, you need to be utilizing the urge suppression. Every time you need to feel like you need to go to the toilet, think to yourself, what? You know what? You should be able to drink a lot of water and still follow that. I'm going to give you 2 guidelines, okay? I'm going to give you 2 guidelines, and if you can stay within these, because here's your next guideline. For your urine flow should be at least 8 seconds, and for men 12, okay? So if you're drinking a lot of water and you're going to the bathroom every 2.5 hours, but you're voiding for like 25 seconds, then you're fine. But if you go to the toilet every 2 hours, and you're only going 1, 1,000, 2, 1,000, 3, 1,000, 4, you don't really need to go. There was something telling you that you needed to go, but you didn't really need to go. So those are your guidelines. Okay? For men, it's 12 seconds. For women, it's 8. It's at least 8 seconds. And that's not 1, 2, 3, 4, 5, 6, 7, 8. Okay? That's... So, one of the things, when we talk about bladder fitness, don't urinate the moment you get home. Okay, you're at the front of the neighborhood, you don't need to go, but you suddenly drive up the driveway and suddenly you really need to go. Okay, you're all familiar with Pavlov's, no, you're not familiar with Pavlov's dog. I know there's some of you, but not everybody is. Pavlov was a psychiatrist. Every time he fed his dog, he'd ring a bell. Okay, eventually he could ring the bell, no food in sight, and the dog would salivate. So this, when you arrive home and you suddenly need to go to the toilet, you haven't suddenly filled up with more urine from the front of the neighborhood to the back door. It's because that Pavlov, your brain, you've set up this pattern, and Pavlov is ringing his bell and your bladder's doing a contraction. So what you have to do is do your urge suppression and stop yourself from going whenever you first get home. Now you've been on a long trip, fine. But on the whole, 95% of the time, what you do at the back door, you stop there. There is this thing called key in the door syndrome, where you put the key in the door and your bladder goes, and oh, now you're losing it. So we don't want that to happen. So do your urge suppression. Break that pattern. Do something else. Feed the dog. Open the blinds. Look at the mail. Anything to break that pattern of arriving home, going straight to the bathroom. Okay, don't urinate in the shower. Oh, I would never do that. No. No, it's great. It's a clean, great place. But what happens is that sound of running water and urinating and the strong connection, next thing you know, you're doing the dishes and you think, oh, I've got to go to the toilet. And you don't even think about it, okay? Because you don't know. But next time you feel like suddenly you turn the tap on and you suddenly need to go, you're going to think, that girl, maybe she did know what she was talking about after all. So, like if we have problems, stopping in the shower is the hardest place to stop, because you've actually let it do it. So, you know, doing that urge suppression can actually feel painful, because that bladder is saying, but you've let me do it all this time. So if you can stop it there, it's a great thing that to increase your ability to hold it. Okay, don't get up at night to urinate, okay? Once a night if you're over 65. If you've had injury to your bladder, if you've got something going on, yes. But otherwise, you'll notice that, like if I was to ask people here, you will find that a lot of you get up at the same time every night, no matter what time you went to bed, no matter what you ate or drank. If you're getting up the same time every night, it's because Pavlov is sitting beside your bed ringing the bell. And you think, but I really got to go. But really, if you went and, because what happens, we get cortisol in our system and it stops the production of urine. So you go and you go 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000. And you think, well, I had something there, but it's not as big as your biggest void. So yeah, there was something there, but you didn't really need to go. So if you can stop getting up at night, my poor boyfriend, I talk about him all the time. When we were first together, he would get up like 3 or 4 times a night. So I sat him down, gave him the lecture, and he's great. But he, now listen to me, young man. Anyway, don't get him. Also, like you shouldn't have to, as soon as you wake up, go to the toilet. Okay, you should be able to lay in bed. So look for patterns that you might be going where you don't need to. No more just in cases. Like a just in case for me would be like I got up at 6 o'clock this morning, I went to the toilet, I got to leave for the office at 7, it's a 30-minute drive, so I better go. No, if I get up at 6 and I go to the toilet, I've got till 9. I can get to the office and treat 2 patients before I need to go. So like girls at lunchtime, they go before they leave the office. They go to the restaurant, they all get up and go together at the restaurant and go back. They don't need, they just went 45, 50 minutes ago. Look at the just in cases. Okay, kids, we're all going to go to the toilet before we go to the grocery store. No. You know, if you're going every 3 to 4 hours. Now, sensible, if you're going on a long trip, fine. But notice when you're on your trip and you're driving down to Orlando and you reach Okahumpka Plaza, how many of you stop? Is it because you really needed to go, or is your bladder recognized that there's a rest area and it's saying, come on, let me see if I can get you guys to stop? You should be able to get to Orlando without going to the bathroom if you're going every 3 to 4 hours. And like, avoid going as soon as you land on the plane, okay? You know, it's just another one of those situations. So sit, don't squat over the toilet, unless you're on I-75 and it's grotty, okay? Don't do anything but business on the toilet. Don't strain when you're avoiding. You want to avoid constipation. I'm going to be talking about constipation in just a second, if I've got time. Do I still have time, Rod? Is everybody needing to get going? I'm going to I'm running, I'm getting there. Okay, recommended fluid intake. 75% should be water, and you should be drinking 6 to 8 glasses, at least 6 to 8 glasses of fluid a day. And you should not limit your fluid intake to increase your voiding schedule, okay? You do not want to limit your fluid intake. Everything you eat and drink goes through the bladder, and there's certain things that make it do this more and contract. So anything with any alcohol, caffeine, carbonation, these are your biggies. These are your biggies. So if you're having a problem and you're getting up at night or you're going a lot during the day, look and see if you're actually consuming some of these things that might be contributing to your bladder. There's different substitutes. There's all sorts of manual therapy that we do in the exercise, in physical therapy, exercise programs, stability stuff. I'm not going to go into this because I want to get into a little bit of the colorectal stuff. Bowel dysfunction. I've already talked about some of the things that we do. You should be having 1 to 2 bowel movements a day. People go, oh, I don't have a problem with my bowel. How often do you have a bowel movement? Oh, 1 or 2 a week. No. The other thing that I'm seeing is these young babies and little kids that are going, the doctors are saying that it's fine for them to be only going like once every 5 to 10 days, and that is ludicrous. I know. See, from our generation, we're going, that's crazy. But what's happening is this decrease in going to the bowel toilet is becoming so common, it's becoming commonplace, and it's not right. And there's things that we can do about it. We actually have a pediatric therapist who does works with bowel and bladder function with infants and children. So there's a lot we can do. Okay, healthy bowels, increasing water intake, decreasing refined sugars, processed flours. You guys are all on the health kick, so you're not doing that anyway. You're exercising, which is great. Eating more fruits and vegetables. I have got a handout on bowel health here. Eating more prunes and apricots. Flaxseed. Flaxseed is cheap, and it's great for your bowel and your heart and your arteries. But it's best if you buy it whole and grind it yourself. 1 to 2 tablespoons a day makes a world of difference. And it doesn't taste bad, and I tell you, it's much cheaper than Metamucil and milk magnesium and all that kind of stuff. Grind it in a little coffee grinder or a NutriBullet or something like that. Fabulous for helping. Happy toileting. Sitting on the toilet, every day. Thinking about relaxing the pelvic floor. We talked about contracting and strengthening it, but somebody's pelvic floor is too tight. We actually have to teach somebody to actually relax the pelvic floor. Pulling the navel in to try and help with the bowel movement. Never avoid having a bowel movement when you have the urge, okay? And when you have the urge to have a bowel movement, even if you've gone urinated like half an hour before, go to the toilet anyway, because the longer it sits there in the rectum, actually it decreases the water content and makes it harder and harder to get out, okay? Avoid hovering over the toilet to have a bowel movement, once again, unless you're on IDES 75 or something like that. I want to talk about toileting posture, because this is an important one. What's happened in our great, modernization is we've actually created this toilet where we sit at 90 degrees, and that is not the optimum position for our toileting posture. What happens is, look over here, this is part of the pelvic floor muscle, and there's somebody sitting at 90 degrees, okay? This puborectalis is still it's still tight, and what happens is our rectum, the bowel movement has to do a right angle turn to get out. Okay, so if you actually raise, see what we've got a little toilet, like a little stool there, and what's happened is we've increased the angle here, and what happens when that happens is it decreases the tension of that puborectalis so that our rectum is more straight up and down and the bowel matter slides out. Okay, I had a patient once who said, there's something wrong with me. I sat on the toilet and my stool just came out. And I go, well, how's it supposed to do? What's it supposed to do? And he said, well, I have to strain and push. No! If you're having to strain and push every time, there's something that you need to be doing to help this, okay? I'm nearly done, guys. There's me and my little squatty potty. The squatty, you don't have to buy a squatty potty, and I'm not advertising squatty potties. But the cool thing about the squatty potty is look how it's kind of rounded here so it slides under the toilet. Bed Bath & Beyond, they have these little stools for like, what, $12, whatever. You can make one. I bet you can. You look handy. But what I'm saying, what I'm really saying is, like there's elderly people out there and they've put them on these high toilets so that they can get off them, right? I mean, it's much easier to get off a high toilet. But what happens is our puborectalis is really tight, and now they have problems with constipation and having bowel movements. So if we can get their feet higher, their knees higher, it can actually really make a difference. There's in the notes, if somebody's having constipation, there's what we call the, this is just doing little massages. Now, the important thing about doing a massage of the bowel is you want to be going around this way. If you go around that way, you're pushing everything back. You don't want to be doing that. You want to be pushing things out. So little massage it like in a little clockwise direction around our navel, but also there is what we call the I love you. Now, this looks a little strange, but it's so that you get the I love you. This is her bottom, here's her shirt, right? So here's your eye. So if you think about the bowel goes up, over, and down and out, okay? So you don't want to be massaging like this. You want to be going down like this. There's your eye, see? Eye, you're all employed by the city. I'm sure you can read. I do that to everybody. It's okay. Eye here. But this is why the picture's like this. There's the L. So you're going to be pushing across here and then into that eye. So there's your L. And here's your U, going down, across, and up. So what you're doing is you're doing a lot. This is for people who have constipation, have difficulty having bowel movements. Okay, I love you. Okay? Physical therapy for the bowel, I'm not going to go into that. We do all sorts of things. There he is again. But I'm going to leave you with the I love you. And I really appreciate you guys coming for this lecture. I hope you got a little something out of it, and if you want handouts, and that was it. Rod, anything else?